Welcome to today's webinar, Upstream Denials, Preventing Revenue Loss Early. This is Ashley Myers, HFMA's Client Services Specialist, and I will be moderating today's session. Now it is my pleasure to welcome today's speaker. Megan Broom is Senior Director of Product Sales at IMO Health, where she leverages over a decade of experience rising from intern to leader to help healthcare organizations improve clinical data quality and drive smarter patient-centered decisions through innovative terminology solutions. And with that, Megan, I'll turn this presentation over to you.
Thank you, Ashley, and thank you to the HFMA crew for having us on today. We're very excited to have become a more active member in the HFMA community over the last 2 years as IMO has started to step more fully into revenue cycle, and it's been a great group to be a part of, to learn from, and to be able to collaborate with in order to help make revenue cycle enhancements and efficiencies where we can. And that's what we're really here to talk more about today, is where there is opportunity in rev cycle and where there are problems that are really being experienced across the industry, regardless of what system that you're in, regardless in which seat that you sit in within the healthcare ecosystem. This is really affecting everyone, so we're here to talk about it today. They already kind of went over my background, but I've been with IMO Health for 13 years, so I do have quite a bit of experience to discuss how we can leverage or navigate clinical terminology in order to help improve the revenue cycle. So who is IMO Health? Why are we here to talk about this topic today? And that is because we are the content provider that is used by 95% of healthcare providers in the United States market every day for point of care documentation when it comes to diagnoses. So we are the engine that allows you to search within your EHR for every which way of saying a clinical concept and to be able to find what it is as a provider that you're looking for without being beholden to ICD-10. We also give you the options to drill down for more specificity within your EHR to really drive better documentation within the integrated EHR workflow. And we've been doing that for 30 years. We've been managing data migrations and data transactions and really powering documentation now, not just in the diagnosis space, but also crossing into procedures and labs and medications and allergens, and have really grown a exciting product portfolio that spans EHR point of care solutions, a continued expansion of those, but also some interesting data quality solutions for downstream secondary usages of data as well. So we are well tenured in this industry. We have over 30 providers here at IMO with over 300 years of combined practicing experience, and we really like to think that we're very provider-led and provider-driven in our efforts. So we are located in Rosemont, Illinois, and we also have an office in Chicago, and we love to have visitors if there's ever anybody that would like to come on site. Next slide, please. Okay, so clinical terminology. As I had already kind of mentioned during my bio, I've been in IMO for 13 years, and this was not something, I don't even know that I really knew informatics or clinical terminology, when I was in college trying to decide what I wanted to do. And as they mentioned, I started as an intern here at IMO, really just looking for an interesting job in healthcare before I wanted to go to medical school myself. And then as I got, towards the end of my, academic journey when it came to starting medical school, and I'd been intern at IMO for a couple years, I really started to recognize this opportunity to be able to leverage a strong foundation of clinical terminology, because everything is built on top of it. And I love this diagram that we use here in our presentations, because I feel like it really visualizes everything that goes into building your data foundation and then everything that is built on top of it. So if there are gaps and there are inconsistencies in that foundation, everything is going to benefit is going to have negative consequences from that. Now, on the other side, if you have a strong, well-maintained, comprehensive data foundation, everything built on top of it will benefit from it. And there are things that are built on top of data that are used for operational efficiencies, like rev cycle efficiencies, business intelligence, operations, but there's so much clinical insights and value as well that are driven off of a solid data foundation. So it's just kind of my personal anecdote and why I am still here after this time and didn't end up going into medical school, because I found that my true passion and true interest lied with how we could improve that clinical terminology foundation so that everything that is built on top of it would have the benefit of that. So that's been really where IMO has been focused over these last 30 years. And why we are here to talk about this today, as one thing that is built on top of that is RevCycle. Next slide. Healthcare has a data problem that spans multiple different areas in the ecosystem, not just RevCycle, but that being the area that we're here to talk most about today. Because, EHRs were not built, to be clinician friendly in most cases. I'm not going to lump every EHR into that. And I'm not even saying it is a negative thing about EHRs. They have to be very comprehensive systems that serve many masters within the ecosystem. And so a lot of times, though, it does feel like the provider kind of does become beholden to a lot of the administrative duties that it takes in order to capture a diagnosis that not only captures the actual clinical intent, but also captures the specificity and the severity of the patient's condition, not just for reimbursement aspects, but also just making sure then that the claim is overall accepted and paid for by a payer. And that is not easy to navigate at the point of care. You're trying to document what is appropriate and what is needed. And there is that extra level then of, but what is my payer going to do when they receive this? Are they going to accept this or not? So there's that secondary step then of this adherence to coding guidelines while you're doing your documentation as a provider. And then, at the point of care, that is, like I said, it's difficult and it can be inefficient. And then what are the downstream ramifications of that, though, is not being correctly reimbursed, having disruptions in the rev cycle, needing to have back and forth communication, getting coding queries back. I've never been a provider, but I've learned one thing over the last couple of years. It's that they really hate coding queries. And I can only imagine as a coder as well, what it is like to sit in that seat and to have to be querying providers that are focused on patient care and don't have time to respond to these queries, but ultimately affects your benchmarking, your ability to get these encounters reimbursed in a timely manner, because everything is around time these days and everything has to get back out the door quickly. And ultimately, a lot of things don't, and they get written off. And so there's just a lot of negative consequences that can span off of whenever a inappropriate diagnosis code is chosen at the point of care or inappropriate sequence is used in the documentation that really are not things that are, burdens that providers could and should, have the knowledge to bear and fix it during their documentation, but are at the end of the day, because this has gotten to be a lot more of a space that payers have honed in on in order to look for things like sequence or specificity in order to drive higher denials. And so ultimately, there is a data problem that is causing that. And there's a variety of ways that we could mitigate it. And we're going to get into that as we continue through the presentation. Next slide, please, Joy. But there are solutions out there, IMO being one of them, but there also are many other RevCycle solutions that are looking to do really interesting and really impactful things throughout the documentation journey. So looking to drive better insights, both through manual interventions and automated interventions, to make workflows more efficient, to help drive better specificity, to be able to get more insights out of unstructured data. There's a lot of those clinical notes. My marketing team tells me about 80% of value is found in clinical notes if we're able to get it out of the notes into a structured format that can actually be documented within the EHR. And all of these solutions are ultimately going to decrease the amount of work that comes back to providers, decrease the amount of work that has to be done by coders, to result in fewer denials and faster payments, better workflows for both providers and coders, which result in less AR days and just overall better data integrity. Because while I'm really passionate about what IMO Health and other solutions are able to do to drive better documentation to help with a reimbursement perspective, my passion really lies with that secondary downstream usage of data as well to drive better revenues capture and to drive better clinical insights and business intelligence insights that can benefit the healthcare ecosystem. However, all of that, really only works if it's driven off of good data that's captured there at the point of care, because that's what's going to trickle downstream. So yes, it's great for reimbursement, but also just great for a solid data asset to be able to use for those secondary efforts as well. Okay, so now we are going to start our first poll question. So for anybody that's on the call, just to make sure that you click into the Zoom invite so that you're able to see the box popped up that will prompt you for your answer to make sure that you get the participation here for today. What we are looking to measure in this question is, while there are so many different reasons for denials, a limitless reason for denials, especially these days, really kind of looking to understand what the audience's experience is like in the highest volume of denials, and maybe not just the highest volume when it comes to quantity, but also highest volume when it comes to the overall impact then on your reimbursement. So some of these being higher dollar, denials than other ones. So just wanting to understand some of the answers. So, what it looks like here, not surprisingly, heavily weighted towards medical necessity denials, followed by conflicting diagnosis, and then closely followed by code first, and then your unspecified lateralities there is the last one. This really aligns with the feedback that we get from the market, as well as what we've been able to see through our own data assessments that we've done. And I'm going to get into some of those numbers of some of the insights that we've been able to derive out of patient data. But this is, like I said, really aligns with our understanding in the areas that IMO is focused, as well as other revenue cycle companies. Okay. And we can now move into poll question number 2. We grouped the poll questions together, just the first 2 here together, and the second 2 will be a little bit later, so that you guys could just be able to be actionable here for a second. Our next question here is, what do you see as the biggest benefit of using intelligent coding content? And what we mean by intelligent coding content is really curated content, not just real broad strokes, large groups of codes, but something that takes goes a step further and really is more clear, of a solution of why things are getting denied and specifically what needs to be done to fix them. So if, a vendor is able to check that box of having something that is, intelligent is the word that we're choosing to use here, what would be the greatest benefit? Is that being able to repurpose coder time towards higher value work than what they're spending today on just the high volume claims that add up? Is that reducing coding queries to providers? Or all of the above, enhancing provider coding education? And, not really surprised to see that answer, as well. All 3 of these things are really great benefits and downstream impacts of having, good revenue cycle solutions in place. So, and these are all things that people in the market like IMO Health are looking to provide. All right, next question. Okay, so what, we've established that there's a problem, and, what is really causing that problem? This is due to an increase in, payer, strictness around a lot of these, denial areas that previously were accepted, and customers just not having the processes and people in place in order to be able to mitigate those. And what are the consequences? Denials, write-offs, and rework. So really looking to reduce those. And let's talk through some strategies of how to do that. So the first thing is by looking into where we should focus our efforts to get started. Because like I said, we can't boil the ocean today, but there is, and there's plenty of denials out there. So where can we start to make them, the most impact fastest? And so what we have seen is that those changing coding guidelines combined with that increase from payers has caused this denial cycle that is just not sustainable. And in order to validate that claim, we analyzed almost 40 million patient encounters. And, we found that just looking at the primary code alone at what the unacceptable primary diagnoses that have been identified, these are things like external causes, manifestation codes, pregnancy gestation codes. There's a variety of social determinants of health. Ultimately, these are ICD-10 codes that can't be used as your primary diagnosis code. And we found, like I said, about 10% of those encounters had a primary code on it that would have resulted in a denial. So we knew pretty quickly from looking at the data that this was a problem worth putting some pen to paper to try to solve. And this has kind of become a little bit of our mantra, if you will, here internally, that has started to be really echoed externally about making the moment of documentation count. While we have providers in that workflow doing all of this work and spending all of this time documenting, let's try to make that as purposeful as possible by driving as much specificity and as much accuracy to get as much value out of that moment in time that we can. And that will limit the amount of rework that needs to be done. And this can create, for some organizations, millions of dollars in net profit uplift when you're able to take advantage of the time that providers are already spending just by getting better value out of it. And so for the current state of the solution, current state is whenever this happens at the point of care, this rework has to be done by rev cycle processes, burdening the providers with the queries that I've continued to talk about. That's because I continue to hear about them. And I really want to hone in on that being a really strong value proposition here if you're able to find a process that can, reduce or eliminate those. And overall, the write-offs too have really started to add up for sites. And some sites are not even allowed to have the level of write-offs that they are. And they're getting into, overall issues with their own reporting. But what we're looking to do through an ideal state is to translate these increasingly complex rules into real-time alerts and physician-friendly prompts, because this is what we have found to be the best mitigation for this, is by doing this at the provider level, but doing it in an extremely thoughtful way. So this allows for providers to more accurately refine these codes, refine the sequence at that point of documentation. It's really avoiding that denial cycle then downstream. Next slide, please, Jory. So like we have talked about, and you guys confirmed through your poll questions, what is contributing to this high volume of denial? So while not to say that these three are comprehensive by any means, this is just the area that we personally have started, curating solutions for. Are those non-primary codes, your unspecified codes, and I'm including unspecified laterality in this bucket as well, those right, left, or bilateral codes that need to be chosen. But this also encompasses your unspecified codes, but also I will say, have to be thoughtful in this bucket. This is what was hard about the unspecified bucket. There are plenty of unspecifieds that are allowed for billing and you would be reimbursed for, but there's also plenty that you can't. And so this was a big part of the task, was identifying the problematic unspecified codes. And then lastly, those excludes one pairs, the conflicting diagnosis codes. And so the first step in order to come up with a solution for this has been, through our experience, has been to identify a way and a place within the workflow to be able to identify this at the provider level and then curate content in order to drive whatever those workflow changes are. So in this case, IMO curated this content. And the other area that I will recommend for anybody thinking of a solution like this is to curate the content to be very specific. So, just having one large library of all of the non-primary codes, for example, think about what that will allow you to do within the provider workflow. How specific will you be able to get in the messages that you're sending back to them in order to be able to get the best, responses and the best reactions, to these alerts and notifications that are being put in the provider workflow. And even talking through downstream utilizations of the content. So if you have a large non-primary library, then whenever you're trying to use that to place things into different groups, do the automated diagnosis reordering, power your claims edits and your rules within your billing software, you can do that with a much finer tooth comb, if you will, if you have this content curated to just have all your external causes together and all your SDOHs together, because then it allows for flexibility for you to drive rules and to drive logic, to drive workflows that are highly specific to the particular denial issue, not just it's a non-primary, so we're going to treat them all the same. So that was one learning that IMO had as we looked to figure out how we would be able to help mitigate this high volume of denials. And ultimately, sorry, Jory, next slide. Ultimately, we have found that there's a variety of ways to actually leverage that content then. Once you've curated it and you've sliced it out, you can use it both upstream and downstream. And I say and pretty carefully. I don't really say and or, always you can and or this. You can either lean completely into upstream, lean completely into downstream. But I, through my experience over the last couple of years, really strongly recommend more of a dual approach. So having these upstream efforts in place through things like checking whenever you place an order, checking whenever you close out an encounter, or something that is a much more real-time alert, actually, when you're choosing which diagnosis code is your primary one. Having those in place, but not making them hard stops, has been a way that we've had a lot better reception from providers into having these into their workflow. Now, that's not to say that customers have not leveraged any hard stops. They have. That's been very organization dependent, very culture dependent, based off of what they want to, how they want it to present. Some customers have also found ways to leverage some of the content as hard stops and some of the content as soft stops. That's just really depending on, what their overall, organizational goals are when it comes to their various encounter types or their various service lines and how they may want those to be handled. But by putting in those soft stops and having then these downstream efforts in place, now you have this great opportunity upstream of your provider level to capture and to influence as much change there. But now you've got a second stop in place as well. And at that secondary stop within your mid-rev cycle, you can leverage all kinds of different, interventions in order to help fix or check or catch any of these coding errors before it actually gets sent out to the payer. Now, just to go through a variety of ways, if this is not comprehensive, that customers have been able to leverage content, both IMOs as well as homegrown content, in order to drive these efforts downstream have been things like work queue sorting. So for example, not having to have, I had an FQHC in Texas that had two people that manually reviewed 2,100 claims a week on their professional side of the house, just to check to make sure that they didn't have any didn't have any coding issues that they at least knew would automatically cause a denial, things like unspecified laterality and non-primaries. So like I said, 2,100 claims a week that they were looking in order to find and identify those problematic claims. But if you are able to use the content in order to drive logic to do that, you actually can have these ran through an automated process and check to see if it has a code on it that errors out in one of the content groups that have been identified as problematic. And that can throw those into various work queues. And so now that just takes one manual step out of the process of actually having to have somebody manually review them. A, and B, it also allows for easier ways to work through the coding errors, because what we've heard a lot from our rev cycle partners have been that in the coding side, they're having to just kind of go through, catch-all queues. And so they have to open each one up and figure out, okay, why was this one denied? And what do I need to do to sort this one and get this one back out the door, get it out the door to begin with? And it is easier, faster, more efficient to be able to just work through a bucket of everything that doesn't have laterality specified with it, as that's just going to be a quicker way to be able to work through and get those back out the door. Now, the next, few, I'm not going to say are new by any means, doing claims edits, doing rules within your billing software in order to drive things like automated diagnosis reordering or drop this code or identify this. This is not new, but what we hear from sites is that this content, in order to drive these downstream edits and rules, it's difficult to curate and it's difficult to maintain. And it's not, they've experienced issues with the accuracy of it. And like I said, just as ICD-10 continues to update, just keeping them maintained. And so there has been an opportunity to be able to take the same content libraries to drive things at the provider level that you're then also able to use to really rip and replace out logic that you have working downstream in order to have more accurate capture downstream. We do data quality assessments all the time for customers where we measure how well their providers are documenting. So we'll grab there and we'll look and see, okay, what volumes are we seeing in these various code buckets? And then we also look then after the mid-rev cycle works through all of the codes and all the edits have been hit, everything has been reworked. What is the effect after? And we do still see that there's quite a bit after all these processes and people that have gone through this in order to fix these coding errors that still ultimately exist and get sent out to the payers. And that causes that whole denial cycle like we've kind of been, referring back to throughout this presentation so far. I'll give another, real life example where a customer that we work with in the southeast part of the country had used inpatient content in order to drive outpatient edits and downstream rules. And they, of course, were experiencing a lot of just issues with that. But they'd already had the inpatient content curated, and it was going to be too difficult to recreate content for outpatient. And so ultimately, they just tried to repurpose it and hoped that it was, the good old 80-20 rule that sometimes we're all going towards. However, what they found is it broke, more than it fixed. And so ultimately, customers, like I said, have seen great value in being able to have the same content set that is driving both their provider logic as well as their billing logic, and have seen much greater results of comprehensive capture and accuracy capture when it comes to identifying these and fixing these before they go out the door. So I'm really kind of passionate, and one could even say a bit pushy, about making sure that you really think through what the overall ecosystem approach is, because I don't think that just having one mitigation is going to really have the impact on reducing denials, reducing rework, reducing write-offs that we're all here to learn about today. It's more so of a multi-pronged approach that I think is really going to be the best intervention by impacting different people throughout the process and to be able to capture as much as possible. And so one way that IMO does this, and I'm sure this is not unique to us, but it's by really learning your processes, meeting with your teams, understanding your workflows, and then we can make recommendations based off of our comprehensive staff of both clinicians and coders to be able to recommend the best places within your particular EHRA and then your particular site's workflows in order to drive the best success. Next slide, Jory. I like visuals, so we wanted to throw in some examples of visuals of how we have been tackling this with other EHRs. You can, kind of get some ideas of how, once you have this curated content, just some, like I said, just some, kind of ideas to jump off from of how you can leverage this in the provider workflow. This is to say, though, that at this point, people, at least with IMO's content, we're probably getting over 10 to 15 different integrations that we've seen at this point. And by different integrations, what I mean is different places within the workflow. So like one is when you place your order, and the second is when you close out your encounter, and the third is actually when you mark the diagnosis code as primary. Due to the variety of EHRs that IMO supports, we have all kinds of different paths that customers have chosen, and we can really work with customers to support that. But I do like to mention that this is a lot of times native EHR functionality. And so while there are partners like IMO Health that have curated content and solutions to help with this, a lot of this too, you can, try to leverage homegrown efforts and homegrown functionality to also. So we just wanted to give you some ideas of how to do that. So this is an example of when a provider is actually closing out the encounter. So when they're hitting that sign button, these are an example of validation checks that they can get. And so these can be hard stops or soft stops in this particular EHR, but this is a common functionality that is, replicatable in many different systems. And so we are able to present this information in a way that is very specific. And this goes back to what I talked about around, thinking about curating content. Be thoughtful about slicing it up into those thinner slices, because that's what allows for you to have this more specific messaging. And without this, we pretty much can tell providers things like error, fix it, or unspecified, specify more, and that, I think, we're not going to have the best reactions and response to those, because I don't think that they're very clear or helpful. And what I heard from the very beginning of this journey from providers, both externally and internally, if this overfires, it misfires, we're going to be out of business. And the other thing is if it's not clear to me why you are telling me something and what I am supposed to do about it, then please do not let me know. And so that's where we really tried to listen to that provider ask and be as clear as we possibly could about why this primary diagnosis isn't allowed for billing and what you need to choose instead. Now, these are just an example of messages. Some customers have chosen to be a little bit more prescriptive of what they want them to choose instead. Ultimately, these messages would be coming from the content logic. In this case, these libraries of codes that have been curated would be driving this automatically. So when they go to close out the encounter, in this case, that primary diagnosis code is going to run against all of the libraries that IMO has curated. And if it errs out on one of those libraries, the top left one, for example, the external cause one, it's going to pop up the external cause validation check. And then you can see the other examples here as well. If it errs out on any of those, then it will give you that specific message. So it doesn't require a coder to catch this and then send this particular tailored message back. This just happens automatically by using the content in order to drive drive the logic. And like I kind of talked through around the power of the soft stop versus the hard stop, as we had customers put this solution into place, we had a lot of them started off with dual builds, really that had both hard stops and soft stops. And we measure data based off of before they put it into place, then after they put it into place. And it became apparent pretty quickly that there just wasn't a significant difference in those results, whether they were leveraging hard stops or soft stops. Even customers that had both, I was seeing that this average around 65 to 72% of these coding errors being reduced in that first month that they were live. 75% of the ones the providers clicked into were identified via soft stop. And that really proved to me that if we show this at the right place in the right way with the right level of specificity, that providers, we do not have to force them to or stop them completely in their workflow. They will click into them and they will fix them. And that's not something that, like I said, really have to trust on anymore, because we have the data to prove that, and to back that up. So I'm trying to think if there's anything else I want to share. These are very similar warnings that fire whenever a provider places an order, because, for example, I talked about how this one is whenever the provider signs the chart, but then the order has already been placed and it's out in the ether with an unacceptable primary diagnosis that will have to be fixed. So while this is not as smart as medical necessity yet, and I want to be very clear about that, while that is on IMO's roadmap, right now it's really just these ICD-10 codes can't be used to place any order, and these are yet again ones that external labs are going to crack down on, payers are going to crack down on because they're going to get denied on them as well. So like I said, you can place these at the order level, at the close encounter level, both. But this is just an example. Next slide, Jory. Okay, looks like we have our last two poll questions. So if you could navigate back to the Zoom screen, just to make sure that you're able to get credit here. Which of the following creates the greatest impact when reworking denied claims? Is it those provider queries? I know not everybody sends them back. And that's because a lot of the time it's not really worth it, because these, volume of encounters really add up. But on the onesie, on the one-offs, they're sometimes they're not high dollar enough to even justify that rework. And that just, is what contributes to the write-off, which goes into our second answer. The last one is, longer AR days, that delay in cash. Is that your greatest impact? Limited coder resources. Now, I know, of course, we could have put in all of the above here, and I'm sure probably would have gotten a lot of answers in that bucket. And this could require a little bit of thoughtfulness about, what really is that greatest impact, because these all are negative impacts, but kind of wanted to hear from the group, at least what your perspective was on the top ones. And see kind of validation here where we're a little bit, kind of evenly dispersed out between the various options. It is interesting to understand that the longer AR days is one of the, the greatest impacts that the group sees. It'll be interesting even for IMO Health to understand more about some of the consequences that drive off of those AR days, as that's what I tend to find in this is this causes this, that causes that causes this. And it just always kind of creates this growing problem, once it starts from that, primary diagnosis code that's chosen. So, okay, thank you so much for your answers on this one. This is our last poll question. When addressing denials, what is considered a comprehensive strategy? This is our only one where we did kind of have a little bit of a biased answer of what we thought was the right answer, but we want to kind of understand what the group thinks here. Kind of the perspective that we came with when it came to where we were, how we kind of came up with these answers. Is it a comprehensive strategy just to send everything into the payer and see what they send back, just see what they ultimately deny? Is it best to really just focus those investments and resources on provider education and really just try to influence behavior that way? Is the best strategy to do a combination? Lastly, is it best to just try to go back to the payer and, go back to the table with them and, fight back against these denials and try to negotiate and see if there's any, success you can have in that area? Well, so either you guys are just agreeing with me to be polite, or hopefully you do agree with me that it's ultimately a combination, really, of all these strategies. It is provider education, and you know what? That's actually one thing I don't know that I hit enough on during that the previous slide. So I'm actually going to talk a little bit about that provider education piece, because when we started this journey, you know, the goal was really to reduce denials, rework, and write-offs. You know, that was kind of our North Star that we were going towards. But what ultimately came out of this experience was this opportunity at coding literacy that, like I said, I don't even know that IMO necessarily intended. However, that's what has been loud and clear from the market that has chosen to put in an intervention like IMO is showing here, that you're not making me mad. You're actually just teaching me the coding guidelines once and for all in a way that is very passive, in the way that we consider to be nudges, that really just are going to teach me them over time, where I'm going to stop doing this and getting these to begin with. Yet again, not things you have to trust me on. At least this is something that we've been able to prove out through our own data to see these provider nudges go down over time. So do you still need a solution that is, you know, a subscription model? Yes, I believe so, because these coding guidelines are going to continue to change. And IMO at least has decided to continue to curate that content as that target continues to move and as that target continues to get larger. We are going to continue to curate more content. So in that regard, it's good to have a solution that will continue to grow, as I'm sure payers are going to continue to become more strict on other areas in ICD that they haven't already uncovered today. On the other side, new providers start all of the time as well. And so on the one side, they will benefit from these, coding nudges and be able to learn from them in the same way. However, we also had one of my favorite stories a couple months ago was from a provider that just had really come out of med school. They were so excited to get to practicing medicine, but they admitted that they felt insecure about, creating a denial issue for their organization, and that they'd been spending time learning medicine, not learning the coding guidelines. And so their, organization had put in a solution like this. And, their feedback was, this is something that I have learned from that's going to benefit me the rest of my practicing career. Whether I stay here, whether I go somewhere else, that now I just know, what I can and can't do. And I learned in a way that actually worked. So those are just some kind of double clicks that I wanted to do on how this has really become more of this coding literacy solution that to me is really just solving for the issue a little bit more holistically, instead of just constant reactions, the back and forth. We could continue to all do that all day long, or we can kind of take a step back and say, providers are very smart people. If we put this in front of them in a way that makes sense to them, they also want to treat patients. And so they can, help adapt these, because like I said, those downstream efforts alone are not catching enough of these. So these two efforts in place will get this down to a level that is manageable, and you can focus on much higher value work than getting right, left, or bilateral onto things. I mean, I just talked to a provider a couple of weeks ago that told me, he was shocked. He said, "You're telling me that if I hit unspecified in that unspecified laterality bucket, that payers don't accept that anymore?" And for the most part, no. I mean, just last summer was Blue Cross Blue Shield deciding they were going to deny 100% of unspecified lateralities, but this hasn't been around that long of them being this aggressive on these various areas, and it hasn't even made it to all of our providers even to understand that there's been these changes. And I do talk to organizations that have decided to invest in things like, coding education, just, third-party vendors that do like in-person coding education, or modules that they have them go through. We've also talked to a lot of customers that have engaged with, frankly, really expensive consulting, firms that have gone in and they've done an evaluation of what's causing these issues and have made these big recommendations on workflow changes that really would require some pretty significant workflow changes, where what IMO has found to be a very acceptable solution and a powerful solution has been to actually be able to just nudge within the existing EHR workflows and be able to see great success from that. Next slide, Jory. This is just another example of how you can prompt this within the EHR. I don't know that the animation, Jory, can you see if you can click back one to see if that animation worked? Hit it again. It didn't, but that's okay. So I'll walk you through how the animation normally would work. So it will this is just kind of a mock-up EHR. So you can see it's like the little IMO EHR. And over on that right-hand side, this is just an idea of when you would mark it as primary, you can get a real-time alert like this. Some organizations have chosen to put in something very real-time. I have found that's a smaller camp, but usually a pretty passionate camp about like, I don't want to wait until I close out the chart. I might not do that for a couple of days. I want to know just right when I do it. So that is an option, or an option, like I said, is a little bit further downstream. This is something that ultimately within your own system and your own organization, depending on the capabilities you have available to you and depending on the content that either you purchase or you curate yourself, you can drive things within various areas. But I just always like to kind of open customers' minds to the various places within the workflow and the various ways ultimately that you can surface this. Next slide. Okay, so ROI. I mean, this is, a high topic point of mind for probably everybody on this call. I mean, and I've been in IMO 13 years. I've been, supporting our sales team in one way or another over that 13 years. And ROI wasn't even something we really talked about when it came to a lot of at least our solutions, up until these last couple of years, where it became a need that not only did something have to have a financial ROI, a hard ROI, dollars and cents associated with it, but it also had to be measurable. And things are hard to measure because ultimately not anybody is usually putting in just one intervention. People are trying a multitude of interventions. So trying to measure which impact is coming from where can be difficult. And also sometimes you're spending more effort than is worth it after the fact to be able to measure the impact of it. And so just be so much easier to be able to invest in a solution that is easier to be able to track the success of it. So whether or not you would leverage someone like IMO Health to do this or yourself, putting these workflows into place in the EHR, you can measure before and after snapshots, of what these volumes look like. And so moving into the next slide, I wanted, actually, Jory, I'm going to be annoying here. Can you move into the next slide and then we're going to actually pop back to this one? Thank you. So this is just an example of how you can quantify, you can project this, and then you can measure after the fact. I just want to open your minds to some ideas here. So this is an assessment that you could do that would take a look at, for example, a month's worth of data in this case. And this would be looking at whenever the provider had finished documenting and looking at what the volumes are like. If you kind of know within your organization, like, yeah, we have a denial problem, but is this the cause of our bleed or is this the cause of our bleed? Because we only have so much money and resources to put to stop these bleeds. So let's focus it at the highest need area. And so this helps uncover that and helps validate that. And also, like I said, it helps track then if you do decide to put it in an intervention, you can grab a snapshot like this again and see how well it worked. So what we have found to be valuable is kind of looking across these code groupings like we've talked about, specificity, sequence, conflicting diagnoses. How many codes is this happening? How many codes are being used uniquely, that are causing this issue? So in this, example, this is 293 unique non-primary codes, but they were used over 1,000 times during this month's time period. And then you can see for the subsequent buckets, the similar numbers. Now, this is something that, at least within IMO's framework, we can even drill down, and oftentimes we do, of even letting them know based off of service line or specialty where the biggest areas of bleed are coming from. We can even look into different areas in the organization, like your ER versus, a clinic, and be able to see what your volumes are. So depending on your own system and where you have your data stored, ultimately will impact the slicing and dicing that you can do. But this is just some ideas. Like I said, that's the biggest thing I wanted to do on this call is I wanted to talk about this issue and just, I don't probably think I need to educate a ton on necessarily that there is an issue or why this is. This is probably something that a lot of the people on the call today would deal with every single day. But I did want to open your mind to ways that you can help, identify it, and then ultimately ways that you can help solve for it. So like I said, just kind of trying to share some ideas here. So ultimately having a viewpoint like this, then if you kind of aggregate those numbers and say, all right, let's take some rough numbers. You don't have to take rough numbers. Some organizations have done some pretty strong analytics here. And they say, let's say we rework 3/4 of these ultimately. Let's say ultimately 25% get written off. And if we use some averages, a cost to rework, we use 15 minutes here. We weight that usually national salary averages, 90% coder salary, 10% provider salary, because not everything is going to go back to a provider. That comes to around $40. There were some numbers posted last fall that kind of benchmarked between $40 and $95 to rework and resubmit. I talked to an organization recently that said that their analytics team had kind of benchmarked it at $15 a touch. So $15 by the coder, $15 by the provider in order to get it back out the door. We can put, what is most accurate for any organization in here. And you can kind of see from an expense standpoint, what's our expense right now in having to catch these and having to rework these to ensure that we're paid. And then on the other side, not just a reduction in expense, but an increase in reimbursement for the ones that we're either currently getting written off or we're currently just getting a lower reimbursement because we are not able to get that extra specificity that is needed. And we use a conservative Medicaid average here of $150 for an office visit, and what this could mean from an increased reimbursement standpoint. And so that comes to kind of a comprehensive ROI that just has that reduced expense and the increase in financial wins as well, kind of coming to an overall value that can project what it would mean for your organization if you invested in somebody like IMO Health, or you invested in your own resources and staff and subject matter expertise in order to drive some sort of a solution like I've demonstrated for you today. These are the sort of value that you can see. And so this helps us make the determination if this is a smart decision to go into for an organization. And then, like I said, this provides that pre-snapshot. So then we can measure this after the fact. But 4 weeks has been the kind of time period for me to see how well it's working, but given it 4 weeks to at least get customers comfortable enough with it. And then we pull these numbers again. Now, sometimes it just worked so perfectly out of the box that I don't have a lot of recommendations to give back. And I'm just able to give them this great report card after the first month and say, look how well this worked. And we can measure this and show you this. But the other cool part is when we get insights that actually allow us to make recommendations to improve. So after you put a build like this into place, you can measure and see how well the various service lines are doing. Just a real life story from a couple of weeks ago. I measured for this customer. They were at about a 62% reduction in that first month that they'd been live. And they had put all soft stops into place to achieve that 62%. And when I looked through the results, they were really great. But I don't know that their ENTs clicked into a single thing. I think they blew past every single one of them. And so that resulted in quite a bit of missed opportunity for this organization. So they were going to go back and they were going to talk to their internal teams, their internal ENT providers, and to just first off start with, are you aware of this? Did you know you were getting these? Do you know what you're supposed to be doing with these? And then going to see how well that intervention worked before potentially thinking of other things, like even potentially raising it to a hard stop. But that was an interesting insight, for that organization to see where they were already getting a really nice return on their investment, but where they could have an opportunity to get a greater return. So that was an area. Another area that I have been able to communicate recommendations back to customers have been around areas where they may need to improve their build to be more comprehensive. So, for example, I was looking through a customer's analysis after they'd put the solution into place and saw that they had tons of genetics counseling related terms that were still getting hit in that non-primary bucket. And so communicated that back to the customer. In their particular build, they hadn't pulled in the encounter that would hit for genetics counseling to receive the validation check. And so that's why the providers that were doing those weren't getting these checks, and therefore they were still making these coding errors. So they pulled that, put that into place, and then I didn't see any of those come through the next month when they sent data over to IMO Health to take a look at. So this is just an idea for you of how you can measure and project out what the value could be, and then also how you can measure it after this is put into place, and ultimately how there can be insights out of that data that give you greater areas of improvement. And then going back to that slide, Jory, I just wanted to show what one of our customers, Dr. Greco from Metro Health, was a large partner for me in order to build what IMO has built in order to help reduce this problem in the industry. We worked together for about 9 months before we put our solution out into the market. Based off of all that feedback I'd gotten from providers, I knew that if we missed it, if we overfired, if we weren't accurate, they would roll this back, they would turn it off, and getting that trust to turn it back on would be really hard. And so we really wanted to make sure that we had curated content that was done in a way that was most appropriate and would be most impactful for the best results. And we also wanted to make sure that in this particular EHR workflow, that what we had built didn't cause any unintended downstream, effects. And so this is a model that we have continued to replicate with our other EHR partners as well to continue to scale out this solution. However, like I said, this is also, content and ideas that I hope that you can also be able to take internally if, to be able to see similar results here, like Dr. Greco was able to see for Metro Health. In that case, what ultimately Dr. Greco recognized is the really hard part was the content, the curation of it and the maintenance of it. And that was what IML Health used our core competency of clinical terminology in order to curate in this case. However, I think that this is a solution that, could be powerful in a lot of ways for organizations. You'll see here for Dr. Greco's use case, we delivered over a 10 times annualized ROI. As the person that put that together, is pretty conservative. Since then we have grown, quite a bit in those effects. But you'll see that what I really cared most about, though, outside of the financial ROI, was more around what those reduction in denials were and what those savings in coding hours. So over a full-time employee's worth of coder hours were saved. Not, letting go coders by any means, just reallocated towards much higher value work than what had been spent on previously. Okay, and then Jory's. Okay, we're here kind of at the 50-minute mark, and I know that there's some questions in the chat that we want to get to, but really our key takeaways is the market is changing, payer rules are changing. What was okay a couple years ago now is not okay any longer. So our previous processes are no longer going to be okay. And we need to think about how we can make improvements within the workflow, both upstream and downstream, in order to help reduce this and overall increase your reimbursement. And that's really what we're looking to do. We know that margins are really, really tight at health systems. We see it in the news every single day. And so if there is an area where we can help or have given any guidance on this call, we hope that you can see that effective denials management really has to have a comprehensive approach, but we believe that by using a content-driven approach, you can really have some real success, here. So those were our kind of key takeaways from today's session. I hope that this was informative and interesting and gave you some ideas of how you can make some improvements in your organization to help improve the lives of both coders and providers and overall the financial health of your organization.
Thank you, Megan, for that engaging presentation. I would like to invite those listening to enter your questions into the Q&A box located on your computer screen. I'll start with the first one. With the high volume of medical necessity denials, what can we do with clinical documentation templates to decrease denials?
I believe that within medical necessity, there's going to be, I could probably talk about this one for quite some time, because I think there's a variety of reasons that current solutions are not really checking the box and hitting the mark right now. First off, I think that's due to how the content is delivered into the EHR. I think there's a lot of integration issues there that make it difficult and time consuming in order to get these rules integrated into the EHR. And then on the second part, then, if that's so hard to integrate in and they're updated so frequently, those two things can't exist at the same time. It can't take me forever to get the content in and that the content's always changing. And so that's another issue that's difficult. I will also say that underlying code mappings in procedures within a lot of EHRs is weak. There's a lot of LOINC mappings, for example, for things that are required for regulatory requirements, state reporting, but not for interoperability or for driving logic within the EHR of what is okay. If you want to be able to build rules that fire off of things like ICD and LOINC connections, ICD and CPT connections, ICD and ARCS norm connections, that it requires all of that data to be there in your foundation, to kind of go back to my very first slide from this presentation. And the last thing I'll say around medical necessity is how much is hidden in those notes as well. And so there has to be an approach that has rock solid code mappings in that foundation, so that any logic that you do drive in the EHR pulls out of unstructured text to reconcile all this information, to do this checking in a way that stays up to date with the payer rules that are very diverse in this country and change frequently. that's a pretty big task in order for somebody to figure out. IMO Health hasn't done it yet. We don't have a medical necessity product today. There are other solutions out there in the market, but that's really, how I think that it can be best tackled is by improving those foundational code mappings, unlocking your unstructured text, and having updated rules that are easily integrated into the EHR that are prompting within workflow, and also using EHR workflows to do as much automated work as possible, I think is going to be the key to that solution, and something that I look forward to continuing to delve into with our IMO subject matter experts to see if there is a way that IMO could potentially deliver a holistic solution like that.
Thanks, Megan. So how can organizations foster more collaboration between coders and providers to improve documentation?
That's a great question. I was out in an on-site, out in California a couple months ago, and I met with the providers on the first day, and then I met with a group of providers and coders the second day. And when I met with the providers the first day, and we talked a lot around these denial issues, there was a lot of blank stares in the room but I'd already done the data quality assessment. So I knew that there was a problem here. But the providers really just seemed to be kind of, a little bit surprised, to hear about these various issues. And so then when we had that dual session with the coders the next day, and we brought this back up, and I kind of mentioned and highlighted that feedback we received previously, kind of the head of the coding department said, well, that's because we're working so hard to fix these for you that you're not having to be aware of the volume of issues that we're experiencing. So I think that at least in that case, it seemed like there was just like a communication gap between what the coders were dealing with in their day-to-day lives and the changes that they had experienced that had resulted in these negative consequences, and then what the providers actually, their understanding was truly that they weren't aware of what these denial issues were that they were causing for their coding team. So I think that there needs to be opportunities to foster more communication between both of those groups in the same room at the same time in order to help with some of that mismatch between overall what the expectations are of each group of each other. And I will say that through a solution like I've showed you today, it requires, or what word am I looking for? It really pushes communication between providers and coders. And I will say through putting in a solution like this, you'll drive a lot of that just naturally, which has really fostered a much better experience between both of those groups. I've always kind of, one of my little quips throughout this experience has been, a lot of times we make solutions for providers that make providers happy and don't make coders happy. We make solutions for coders that make coders happy, and it doesn't work for both camps. And I feel like what I've shown you today has been a unique way of tackling this that has actually been able to make both camps happy and be able to work better together.
Awesome. Thank you so much. Do you have any closing remarks, Megan?
I don't. I am so happy to see all of the various questions here in the chat. We will follow up with you after today's session to address these with you personally. And the last thing I will say is, up until a couple of years ago, IMO was well situated in clinical terminology, and we were doing a lot of interesting things downstream with secondary usage of data for research and analytics and all kind of cool stuff like that. But it was from our market looking to us as a partner to see if there could be any potential help that we could give as that content provider to be able to drive a reduction in denied claims is the whole reason that we started our own foray into this area and have been able to have these results with customers. So we hope that if you are already an IMO partner on the call, just continue to always look to us and think to us as a partner, because we are always looking to drive solutions that make the biggest impact in our market. And this is a problem well worth solving and putting some time and effort to. So if there's ever any way that we can support or help, just please know that we are here to do that, whether if that is through a solution from IMO, somebody down the road that we know of, our many friends in this industry and health tech, or even just being able to give consultative feedback to you and what you're trying to accomplish. So I appreciate you giving me the time today. I hope you found this to be interesting. And if there's any way that we can ever support you, just let us know and we're here to help.
And with that, we have reached the conclusion of today's webinar. I would like to thank our speakers and IMO Health for sponsoring. We hope that you found this presentation informative. Thank you for your participation. Have a great day.